Hello, everyone. Thank you for making time for this talk. Um, can you hear me and see me properly?
Yes, sir.
All right. Thank you, Dr. So this, is a talk again oriented towards our physician, pediatrician, and general practitioner friends who are practicing in the community. And every now and then they get a patient who has some kind of bleeding manifestation. They're often at a loss as to what to do, what not to do, what should be the emergency management, who should, get further evaluation and who does not need further evaluation. So to kind of clarify these, I thought that we should have this kind of a session. Um, this is going to be a completely practical talk. We would not be talking of theories of coagulation and the latest in terms of genomics, etc. It's hardcore clinical, completely oriented towards helping our friends manage the patients better. Um, all right. So we will discuss what is a blood clot, what are the different types of bleeding, how do we evaluate patients, how do we categorize our patients into who needs evaluation, who doesn't need detailed coagulation workup, how do we manage the patients. What we are not going to discuss is drug-induced bleeding. So I'll not be talking about those patients who present with bleeding because they are on, say, aspirin or warfarin, acetrom, or the novel direct oral anticoagulant. We won't be discussing drug-induced bleeding. That's a pretty straightforward clinical scenario, and most of the doctors are pretty well versed with how to manage such patients. So, uh, uh, starting the talk, let me just first discuss how a blood clot is formed. And this diagram is the cross section of a blood vessel. What we need to first understand is blood vessels in our body, which carry blood and the blood cells and plasma proteins and various other chemicals, right? Biochemicals. These are nothing but pipes. Blood vessels are pipes, where there are arteries or veins or smaller microvasculature, right? Arterioles, capillaries, venules. And these pipes, they have two purposes. Yeah. One is to ensure that the wall, the thickness of this pipe is sufficient enough to ensure that the blood flows smoothly. That's the first thing. The To flow smoothly, blood has to stay in a liquid state. Correct? It's a liquid. It's a fluid. Only then can it flow from the heart to the every part of the body, and at the same time, it has to carry the blood back to the heart for further circulation. Blood has to go to the lungs to pick up the oxygen and expire the carbon dioxide. So the blood has to be liquid. That's the first job that has to be done. The second job is, by chance, if there is a break in the blood vessel, you can see this is the vascular endothelial lining. And if there is any break, any damage, either from inside or from outside, if there is a cut, if there is a trauma, then the blood vessel has to ensure that there is no leakage of this liquid. And that is done by means of creating a blood clot. And what the blood clot essentially is at the area of damage, the blood which was liquid converts into a solid temporarily, converts into a solid clot. And that clot then plugs this break, it plugs this gap to prevent leakage of blood out of these pipes. Now, the interesting thing is, how does this happen, right? How does blood stay liquid, and how does it temporarily turn into a solid at exactly the spot where it is required? Uh, for that, nature has created a beautiful system. So you see, the vascular endothelium is a very nice, smooth inner lining, inner surface of these pipes of the blood vessels. But just below the vascular endothelium, what the blood vessel wall has is collagen, and it has something called as tissue factor. Normally, collagen and tissue factor, you can see they are below the vascular endothelium. But wherever there is a break in the endothelium, a tear, a cut, any kind of trauma, the blood then gets exposed to collagen and tissue factor. This triggers a local clot. Yeah, this triggers a local clot. How it starts is, first of all, the platelets which are floating around in the blood, they come and they start sticking. They start sticking to this ruptured part of collagen. Yeah? And they stick to each other, they stick to this part, and parallelly, the tissue factor, which is now released from here into the blood, excuse me, that tissue factor will bind to factor 7. And these two things, they go parallelly and they initiate a blood clot. Going further, the coagulation cascade, which is triggered because the tissue factor gets attached to factor 7, that we all of us know the cascade, the various reactions. I'm not going to get into the details in this talk. Remember, those purely clinical. So all of that results in fibrin threads, right? Fibrin, you see these blue ones, those are the fibrin threads. And the fibrin threads, they entangle these platelets, make it kind of a strong clot. And at the same time, the RBCs which are floating in this area also get trapped into that clot. So one way to look at it is platelets and RBCs are like bricks, and fibrin is like the cement which holds the bricks together. This is how a very localized blood clot is formed. And if we, take a patient's clot and section it and look under electron microscopy, we see these three elements, the three components of the blood clot. So we see the fibrin strands. Within that, we have a lot of RBCs which are trapped and also platelets. Of course, there are a lot of details in the kind of coagulation pathway reactions which happen. There are a lot of details about how the platelets themselves propagate clotting, and then later on they lead to retraction, etc., etc. Again, we are not going to get into this. But it's important to remember that for a clot to form, we need platelets, we need the coagulation factors, which ultimately result in fibrin threads, right? The entire sequence. And we also need RBCs. What this means, practically speaking, is if a patient is bleeding and I want to stop the blood loss, if I want to promote coagulation, then I have to ensure that the patient has all the three things. So the patient should have enough number of platelets, and these should be functioning platelets. For example, if my patient is on aspirin, then the platelets may be there in number, but they're not really working, right? So I need platelets enough number, and they should be able to do their job. We need the coagulation factors, all of which lead to ultimately the production of fibrin strands, and we need RBCs as well, right? Now, moving forward, when any of these go down, how does bleeding happen? To make things simple, we kind of divide the clinical patterns of coagulation issue into two types, right? So the first is a bleeding disorder, and the second is a clotting disorder. A bleeding disorder happens when there is superficial bleeding, and by superficial we mean the skin and the mucous membranes. So this will lead to from tiny petechiae purpurae to ecchymosis, bruises on the skin, in the mucosa. It can lead to gum bleeding, genitourinary bleeding, so hematuria, or menorrhagia, melena, hematemesis, so any kind of mucosal bleeding. And this is generally due to a problem in the number of platelets or the functioning of the platelets. How do we test for these? We do a platelet count and we look at the bleeding time. Now, bleeding time is a very simple screening test for platelet function. If there are enough platelets to see whether they are doing the job, we can do a bleeding time. Although in coagulation labs, we no more use bleeding time, it is considered to be obsolete, and there are newer machines, equipment which are available, which are far more accurate. However, it goes without saying that in the community, bleeding time is still a very good test to look for platelet function. How do we treat these patients? We have to give them platelet transfusions, right? Pretty simple. And problems with platelet function can be due to drugs, aspirin, etc. Or they can be inherited congenital problems such as Glanzmann thrombasthenia or BSS, that is Bernard-Sillier syndrome. So this is one pattern of hemorrhage, that's bleeding. The second pattern is what we see in clotting disorders, which essentially result in deep bleeding in the muscles. So they can be hematoma in the muscles. The hematoma could be in the thigh muscles or psoas muscles in the back. We often see patients with hematoma in the pectoralis major muscle as well, right? So any muscle which goes through wear and tear could potentially bleed internally and lead to a muscular hematoma. Uh, this is the kind of high hematoma that we see in hemophilia patients. Bleeding can also be in the deep cavities, especially the joints. And you can see here, this patient also has a left knee hemarthrosis. Again, there's a picture of a hemophilia A patient. This is another image of a proper joint hematoma, hemarthrosis. Right? All of these are seen in the coagulation factor deficiencies. Now, coagulation factors are, we've studied them since our medical school, right? And factor 1, 2, 3, 4, 5, 6, 7, 8, 9, all of those. And all of those ultimately form the fibrin thread. So coagulation factor deficiency leads to this, and this is tested by prothrombin time or activated partial thromboplastin time. So if either of these two or if both are prolonged, then there is a deficiency of the coagulation factors. How do we treat it? We replenish the coagulation factors. Now, FFP, fresh frozen plasma, is a wonderful blood product. It has all the coagulation factors. So if you don't know what's happening to your patient, you can give FFP. Uh, Cryoprecipitate is another blood product, and it has certain specific uses, mainly for hemophilia A. So these are the two congenital problems which can lead to bleeding, the pattern of which is like that of a clotting disorder bleeding, which will be deep bleeding. Now, let me tell you some very brief concepts of these coagulation tests, right? Basic evaluation. If I want to figure out if a patient of mine, if there are any problems in coagulation, then most important thing essentially is history. It is essential. And all of us see patients who have a history of bleeding, uh, um, spontaneous or after injury, but nobody takes the history. Nobody asks the patient. And then they undergo some surgery, and then there is post-operative bleeding. And if you talk to the patient, they'll say, yeah, doctor, I've been having bleeding. Nobody in your hospital asked me, right? So history is very critical, and we'll come to some details of this. The second coagulation test is what is called as a complete blood count, where we look at hemoglobin, the RBC count, RBC indices, WBC, WBC differential, and the platelet count. So that's the second coagulation test. In this, if you see platelets less than 100,000 or 1 lakh per cubic millimeter, then that's significant. And, we evaluate those patients further. However, there are always patients where the number may be good, but the platelets may not be working. Like I said previously, we have to do a bleeding time, or there are several newer instruments, one of them being PFA 100, which give us a more accurate screening test for platelet function. Remember, these are only screening tests, okay? These are the basic evaluation. We then have PT and APTT, prothrombin time and activated partial thromboplastin time. This is again, these two, if they are normal, then you're practically. So, if PTAPTT are bang normal, if they are done properly, however, most of the labs don't do this properly. But if they're normal, then that tells us that there are enough coagulation factors in the patient's blood. And because there are enough, the number of seconds that it takes for PT and APTT, they are within the normal range. Now, what do we mean by normal? When we look at coagulation factor levels, 100% is supposed to be normal. And even if it goes below from 100 to 90%, 80%, 70, 60, 50, we consider that to be normal. So the normal range for coagulation factors is 50% to 150%, right? 50% to 150%, with 100% being in the middle. So as long as any coagulation factor, factor 8, factor 9, is more than 50%, which is enough for survival, we call it normal. And even the tests are designed in such a way that PT and APTT will start getting prolonged only when the coagulation factors go below 50% of normal. Yeah, that's how the tests are designed. The lower the factor level, as it goes below 50%, you will see the PT, APTT getting de-aged. If it goes down to 5% or 1%, then they are going to be very prolonged. Okay. So how prolonged is PT, APTT will tell us how low is the a particular coagulation factor. What about clotting time, right? Many times our friends call us and say, hey, BT-CT is normal. Well, BT is fine for platelet function. Clotting time is a completely outdated test. We don't do it anymore, and it has been replaced by PT and APT. Yeah, so we should stop sending clotting time. So this is the basic evaluation for the coagulation, right? What about intermediate level evaluation? So then you have some patients, in whom there is PT and APT is prolonged. What we then do is what are called as mixing studies. And that means that the suppose APTT of a patient is prolonged. Suppose the normal range in your lab is say 25 to 35 seconds. Okay. And you have a patient whose APTT is 60 seconds, right? So normal range being 25 to 35 in your lab, and your patient's report says 60 seconds, so it's prolonged. At this point, what we do, whenever we do APTT, we take the patient's plasma, and so whole blood is sent to the lab. The lab will centrifuge it, separate out the plasma, and in that plasma, which is taken in a small test tube, we will put in calcium, we'll put in the APTT reagent, etc., and we will see how much time does it take for that plasma to clot. That is how APTT is measured. In a mixing study, what we do is we take half patient plasma and half volume of control plasma. Control plasma is created by taking blood from 20 healthy normal people. Okay. So what we do is we take blood samples, about 10-20 ml of blood from about 20 people working in the lab, technicians and sometimes the nurses. We measure that PT-APTT. If that is normal, we say, all right, you have normal PT-APTT. I'm going to pool all of your plasma, and that becomes my control plasma. So part of patient plasma, part of control plasma is put in, and then we measure how much time, how many seconds does it take for that to clot. Now, by adding control plasma, if the APTT improves, That means if your 60-second comes down to say 40-second, okay, then that tells us that my patient's plasma was lacking in some coagulation factor, the factor 8 or 9 or 12 or whatever. It was lacking in that, and my control plasma provided the clotting factor which was low. And that is why the prolonged APTT normalized. It improved from 60 seconds to say 40-45 seconds, right? So this tells me that my patient's APTT was prolonged because of factor deficiency, coagulation factor deficiency, right? However, in spite of adding control plasma, if the APTT stays at 60, it does not improve. Then that means that my patient's plasma has some clotting factor inhibitor. It has a clotting factor inhibitor, right? And one of the inhibitors is lupus anticoagulant. So my patient plasma has a lupus anticoagulant or some clotting factor inhibitor. So even when I add control plasma, this inhibitor is not allowing the clotting factors from even the control plasma to work. So in the test tube, I add half patient and half control, and that doesn't help. That means the control plasma is inhibiting, the patient plasma inhibiting even the control plasma. So these are mixing studies. Many labs do this, right? Many hospital labs can actually do mixing study and tell you whether your patient's APTT is prolonged because of a factor deficiency or because of a factor inhibitor. There is a second kind of intermediate level coagulation testing, which is done by small machines, point of care devices called ROTEM and TEG. TEG is thromboelastogram. So what these do is they will take whole blood, patient's whole blood, add calcium, and then it will check for various parameters as to how much time does it take for the clot to form, uh, how strong is the clot, when does the normal fibrinolysis, clot dissolving starts, and all of that. It gives us a global overall understanding of hemostasis. This is again another test which goes, slightly beyond PT-APTT, and many good hospitals and good labs do these tests, and these can also be used for your patients. However, if we want to do a complete comprehensive assessment of coagulation, then we have to send the sample to a coagulation lab. In the coagulation lab, we will look at various actual do factor assays and say, okay, your factor 8 is say 100%, your factor 9 is 124%, blah, blah, blah. So coagulation factor assays are done, proper platelet function tests are done by adding various stimulants to see whether the platelets are working properly. Once we have diagnosed something, we can even do genotyping to understand which mutation is leading to the patient's phenotype, right? So that's an overview of the various tests which are done. Now, let us get into some detail of these tests. And like I said, starting with history. When a patient comes to you with bleeding, the first thing that you're going to ask is this the first time this has happened? Or is this a recurring problem? Okay, let's come to the recurring problems first. If the patient says, yeah, doctor, I keep on getting bleeding from my nose. Every year it happens. Or a lady says, no, doctor, I've been having menorrhagia since I attained menarche. So it's a recurring problem. Or somebody says, no, even last time when I had a surgery, dental extraction, the bleeding was too prolonged. So it's a recurrent problem. Recurrent problems are generally inherited issues. Okay. Again, I am not going to deal with the drug-induced bleeding, right? I'm assuming that you have checked the patient is not on aspirin, clopidogrel, warfarin, or other anticoagulants, not on heparin. You rule that out, then recurring problems could usually be due to an inherited congenital issue. Problem with either the coagulation factors or platelet function. Yeah. And thus, we generally see this in younger patients. Typically, hemophilia gets diagnosed. Severe hemophilia gets diagnosed when a child becomes a toddler. and starts crawling around, starts bumping into things, and then parents say there's some bruising on the skin, or there is a joint swelling. So as the child becomes more active, or a girl achieves menarche, she will start having menorrhagia. So these are generally younger patients who have congenital problems, right? The platelet count is normal. It's a problem with the function or with the coagulation factor level. Your screening test will give you a good information on this. If it's a coagulation factor problem, PT-APT will be deranged. If it's a platelet function problem, bleeding time will be prolonged. Yeah. However, even acquired conditions can lead to recurrent bleeding. What are the acquired conditions? Platelet number. You'll be surprised how many times patients come to us with bruising or hematuria or gum bleeding, and a complete blood count has not been done, and the complete blood count shows that actually the platelet count is low, right? Either it's a immune ITP related issue, or the marrow failure, or aplastic anemia, or leukemia, right? And sometimes it's drug related, and sometimes, very rarely, coagulation defect could be acquired. What happens in older patients is it's a kind of an autoimmune problem. So the body creates antibodies against factor 8 most commonly. And these antibodies will destroy the factor 8 in the blood, leading to low factor 8 levels and thus acquired hemophilia. Yeah. The presentation will be the same. The patient would be older. They will typically say, no, no, I have not had a problem until now, but recently I started having bleeding. And you check the complete blood count is normal. The PT is normal, but the APTT is prolonged. And then you actually do an assay, you do mixing studies, you will understand that even with the half control, the APTT remains prolonged. That means there is an inhibitor in the patient's plasma, which is inhibiting even the control plasma. So we diagnose this with mixing studies. Quite often, acquired problems which lead to recurrent bleeding could also be structural. They don't necessarily have to be a hematologic problem. So, epistaxis could be due to dry weather. We often see it in summer in children because of the dry nostrils. They will, do nose picking. It just leads to injury inside the nose and bleeding. Other structural causes of bleeding could be varices, esophageal varices, hemorrhoids, etc., right? Or gastric ulcers leading to hematemesis. And then, of course, epistaxis in the older patient group could be due to hypertension. So, if we are looking at recurrent bleeding, then these are the conditions that we are thinking of. However, if a patient comes to you with bleeding for the first time, if it's a young patient, toddler, pre-adolescent, then you're again going to look at inherited problems and start thinking, okay, now you're at an age where a congenital problem will get revealed. You know. However, if an older patient is bleeding for the first time, then it's generally an acquired problem. They may have a milder congenital issues, but usually it is a acquired hemophilia or drugs or something like that. So when we start taking history of a patient, we say, hey, is this happening to you for the first time or has this happened before? And based on that answer, this is our outlook. We then ask them, all right, how did this start? Was the bleeding spontaneous without any injury, without any trauma? If so, then that's a more severe issue. If it's a post-traumatic problem, then the coagulation problem may not be that severe. And what kinds of trauma are we looking at? The trauma can be an injury, it can be a fall, it can be a road traffic accident, it can be a surgery. Many times, we get a call because there is unusual post-operative or intraoperative bleeding. Surgery is also a kind of tissue injury, right? It's a trauma. In children who have coagulation issues, they often first present with when they have excessive bleeding after tooth fall. The deciduous teeth, right? Or after some dental procedure. And finally, remember, in women, pregnancy and labor are major hemostatic challenges. When there is childbirth, the after the birth, there is a large raw area in the uterus which can bleed, and the uterus contracts normally postpartum to reduce the raw surface area. So sometimes, coagulation factors are discovered due to a postpartum hemorrhage. What this also means is if a woman has gone through even one pregnancy and delivery without major bleeding, then she probably does not have a major congenital inherited coagulation problem. Because if she had in a pregnancy, she would have had bleeding, right? During the labor and delivery, she would have had bleeding. So, normal labor is a very strong hemostatic challenge. And if a lady has not bled during a previous pregnancy, or somebody has gone through a fracture, an accident without major bleeding, then they don't have a serious inherited congenital hemostatic issue. Menorrhagia is very common in women, and women who have severe menorrhagia, severe defined as if they are passing clots. Remember, in normal menses, the bleeding happens in the uterine cavity, and a clot is formed. A clot is formed in the uterine cavity, and then the clot dissolves. There is fibrinolysis, and thus the liquid menstrual blood then comes out. So there is bleeding, clot formation, fibrinolysis, right? Clot dissolves, and then there is liquid menstrual blood flow. However, when there is unusual bleeding, when there is unusual bleeding, then the fibrinolysis cannot happen properly, right? The clot, the bleeding is so much, the clot is so big that the fibrinolytic system in the uterus is overwhelmed. And that is when the women will pass clots. So if a woman is passing clots, that's unusual. That is, overwhelming of her physiology. Often, women who have menorrhagia will say, "Doc, second day or third day, it's like a flood, right? There's flooding of menstrual blood, or I bleed for more than a week." That's an important. So these are some important markers to tell you that there may be an issue with coagulation. You're then going to ask, all right, so you had epistaxis, etc., and how long did it last? Did the bleeding go on for many hours or days, or after a few minutes it stopped? Correct. Sometimes it stops and then it recurs, which is again a very important thing, because which means that there may be a problem with clot stability. Clot stability. Yeah. You would also ask, how much is the bleeding? Was the epistaxis just a few drops? Or, menorrhagia, like I said, are there clots? And was it so much that the hemoglobin dropped and blood transfusion was required? How did the bleeding fundamentally stop at the end of it? Did you have to suture? Sometimes patients will say, "Yes, doctor, I had dental extraction. Then I went home, there was bleeding, it wouldn't stop. Ultimately, next day, my dentist had to suture the gums to stop the bleeding, to achieve hemostasis." Sometimes they'll say, "No, even after suturing, it didn't stop. Then they gave me platelet or plasma, transfusions, and only then it stopped." Now, this gives you an idea that if bleeding stops after platelet transfusion, then maybe the problem is with platelets. If bleeding stops after plasma, fresh frozen plasma infusion, then there may be a coagulation factor problem, right? Um, some patients will say, "No, the doctor said you have hemophilia, I've given factor 8, coagulation factor 8 injection, etc." So this history is very critical. Now, which patients are unlikely to have a major coagulation problem and you shouldn't bother too much? Those who have very minimal bleeding, few drops of epistaxis due to nose picking or hot weather, dental bleeding with some blood streaked saliva might actually be due to gingivitis, might not be a coagulation issue at all, might be a local issue. There are some minor few skin petechiae, even after injury, there is no bruising, minor bleeding, right? And no wet purpura, so no blood clots or purpura in the palate, tongue, cheek, gums, etc. No muscle or joint bleeding. Patients where the bleeding, they say, no, no, doctor, I've read a lot, but my hemoglobin has remained 13. So hemoglobin never dropped. So obviously, the bleeding was not too much. And now, in this, there is one thing you should remember. Sometimes, subjectively, it may seem that there is a lot of bleeding, especially, hematuria. You put one drop of blood in 1 liter of urine, the whole thing is going to turn red. So, to categorize whether there was significant bleeding, we have to look at the drop in hemoglobin. Patients whose bleeding is very short lasting, stops spontaneously, does not require suturing or plasma transfusion, platelet transfusion. These are patients who are unlikely to have a major coagulation problems. Now, if somebody has gone through major trauma without any bleeding, then definitely major coagulation issues ruled out. If somebody says, yeah, I had appendicectomy or I had tonsillectomy, and no, doctor, that time there was no bleeding, right? Or I had an accident fracture, no bleeding. Tooth fall, dental extraction, postpartum, like I told you, right? And if we are worried about platelets, then if the platelets are more than 50,000 or less than 30,000, but no wet purpura, if the bleeding time is okay, uh, PT INR are less than 1.5 times normal. Now, this is important. You see, if the normal APTT is range is say 35 to 45, and until the APTT is above the upper limit of normal, so 45 seconds is the upper limit, 35 to 45 being the range in your lab. If the APTT is going to above 45 towards 50, then yeah, certainly that's abnormal. Some labs will give APTT normal as just one value. So they will say, no, no, the normal APTT in my lab is 28 seconds, for example. So then you have to calculate 28 into 1.5. That is 42. So until the APTT goes above 42 seconds, above 1.5x normal, um, it's not significant. Similarly, in prothrombin time, if the INR is less than 1.5, it's not significant. So these are patients who are unlikely to have major coagulation problems. We also ask, obviously, one very important question whenever we see a patient with bleeding, whether in childhood, after birth, did your family tell you that you are bleeding from the umbilical stump? Very important history. And that too, the bleeding starts after 1 or 2 days of birth. So initially, the birth happened, umbilical cord cut off, and the umbilical stump was fine, but a day or two later, the bleeding starts. That's because the clot which was there at the umbilical stump is not stable. It's not stable, and it starts breaking, and there is delayed bleeding. This is classic of factor 13 deficiency. This is one history which has to be taken, especially if you're thinking of a congenital issue. Always ask about drugs. Many times patients would be taking NSAIDs for stomach pain, and they may actually come to you with purpura, right? You have to take this history. Many times patients forget that they are taking some medicines. Yeah, my doctor started it, but those are my normal medicines. You should always go through that history. Asking about a family member who had spontaneous bleeding, unusual bleeding, whatever. And many times women will say, yeah, my sister also has menorrhagia. She also requires blood transfusion. Then maybe there's something congenital in the family. Yeah. So that's your history. And this is so critical. I remember when I was training in hematology. I was a resident in hematology. Late at night, I was given a call. I went to the neurosurgery ICU, and there was a 55-year-old man who is in the ICU, and I said, he has post-operative bleeding. Can you please come and see? So I was called for that. So I was dead tired after all the work at 11:30 in the night. I went to neurosurgery ICU. And you've all seen how neurosurgery ICUs are, right? There are ventilators, patients are comatose. And however, this was a 55-year-old man who was sitting on the bed with a drain from the side of his head. And I go to him and I say, I'm from hematology. You had bleeding, and he says, yes, doctor. You know, I had hematoma. These fellows operated. I was telling these people I have hemophilia B. My brother also has hemophilia B. Nobody listened to me. The doctors here, they said, just shut up. And they operated me. And now after surgery, I'm continuously oozing. They're not listening to me. So trust me, history is a very, very critical test evaluation for coagulation problems. Now, let us see which patients will be evaluated in which manner and to what extent. Those who have mild bleeding, which I mentioned previously, few drops, nothing much, menorrhagia, but no clots, not recurrent, no drop in hemoglobin, no bleeding in high risk sites, right? And no muscle hematoma, joint bleeds. Bleeding stops quickly, doesn't need any surgery or transfusions. Uh, these patients just do a complete blood count. You don't have to do anything else, you know. And if the platelets are fine, maybe do a bleeding time. These patients are typically the bleeding is because of something else. So injury, dry nose picking, hypertension, menorrhagia, maybe uterine fibroids, PCOD, etc. So mild bleeding does not require complete coagulation workup, as these patients are unlikely to have a major problem, especially they have gone through trauma and surgery and everything is okay. What about moderate bleeding? Moderate means, yeah, it's recurrent. It does keep up coming, but it's not life-threatening. Yeah, I have some menorrhagia, the lady may say, and sometimes it's really bad. She may say, I have to change 3, 4 pads in a day, sometimes more than that. Epistaxis may be a lot in some patients, requiring hospital visit, nasal packing. There even may be a drop in hemoglobin, and they will say, yeah, every 3, 4 years I need a blood transfusion or I need iron tablets. However, they don't have bleeding in high risk sites. So, no hemoptysis, hematomesis, intracranial, muscle hematoma, joint, no delayed bleeding as in factor 13. The bleeding stops spontaneously, doesn't really require major intervention. And in these patients, yes, they are moderate. We need to evaluate, right? They may be having a mild to moderate coagulation problem. Sometimes type 1 von Willebrand. You know, 5 to 25% of women with heavy menstrual bleeding have type 1 von Willebrand disease, which often gets missed. So patients who have significant bleeding, it may not be life-threatening. It may not require suturing, but it's significant. In them, we have to test proper history, look for local causes, but along with complete blood count, do bleeding time, do PT-APTT. If these are normal, then that's fine. If they're abnormal, then you do a complete coagulation workup, right? So this is how now from just complete blood count, we have gone to PT-APTT and bleeding time and all that. Sometimes what will happen is patients will get referred to you, they would have received a blood transfusion. Now, along with the packed red cell transfusion, some of the donor plasma also comes, and hence the PT-APTT may be falsely normal. Hence, if a recent transfusion has been given before you do PT-APTT or coagulation workup, you have to wait for 4 weeks, you have to wait for a month, so that the donated coagulation factors will, wean away. What about serious bleeding? For example, somebody comes with spontaneous large bruises, yeah, muscle hematoma, joint bleeds, critical organ bleeding, or unexplained bleeding, intra, post-op, postpartum, delayed bleeding as in factor 13, life-threatening, not only requiring transfusion, but a rapid drop in hemoglobin, requiring urgent blood transfusion, multiple units of blood transfusion, and or suturing required. Now, in these patients, there's generally something seriously wrong, and we have to take this more seriously and do a more thorough evaluation. How do we evaluate? I'm going to divide patients who have serious bleeding into those who are in an emergency and urgent situation and those who are not in an urgent situation, because the approach is different. In an urgent situation, what you need to do is you need to collect blood samples it goes without saying, complete blood count. You have to check the hemoglobin, you have to check the platelets. You do a PT and a fibrinogen. And I'll tell you why. Collect some extra coagulation samples, in a prothrombin tube, citrate tube. Collect 5, 6 tubes and just keep them. So you send one tube for PT fibrinogen and you collect 5, 6 extra tubes. Okay. Send for cross matching. Ask for multiple, 3, 4 PRBCs, because if the patient is sick with a lot of serious bleeding, then you're going to need a lot of PRBCs. And sometimes in an emergency, you have to give uncross-matched O-negative unit if the patient is hemodynamically unstable. Along with PRBCs, also order for platelets and FFP. So keep everything ready here, okay? Cryoprecipitate is also something that you should order for. Uh, if the bleeding is too much, you can give the first pack of PRBCs while waiting for the reports, but just PRBC. Don't give platelets and FFP blindly as of yet, right? However, if you have to give more than 4 PRBCs, then you have to blindly give FFP and platelet, and I'll come to that. However, once the reports are ready, if platelets are low, you've already arranged, ordered for platelet units, transfuse them. If PT ability is more than 1.5 times normal, you've already ordered FFP, transfuse them. And if the fibrinogen is less than 150, transfuse cryoprecipitate. Okay, so these are patients who are sick, and you're not going to look for the perfect coagulation report and diagnosis. You're first managing them. However, you are collecting some pre-transfusion extra samples for further analysis. In the beginning itself, you're collecting 5, 6 PT tubes and keeping them. And if your PT ability is deranged, then you can send those extra tubes to a coagulation lab for factor assay, mixing studies, whatever it is, right? And these patients will not stabilize immediately. So you have to keep on checking hemoglobin, platelets twice a day, repeat PT ability once a day at least. And if it was prolonged previously, and transfuse FFP cryo. So this is how we manage the patient. Here, the key is stabilizing the patient, but ensuring that pre-transfusion, you have some extra samples left for further analysis if required. What about serious bleeding, but not an urgent situation? Which means somebody says, yeah, I had this, doctor, but I'm fine now. I'm fine now. Okay, so you have time. You're not actively bleeding. You had serious bleeding last week, last month, 1 year ago. Obviously, there is something serious and I need to evaluate you, but I'm not stressed about stabilizing the patient right now. It's a stable patient in front of me. This is again, I'll take a proper history, I'll do the tests. Many times what we do is transfusions have already been given. We'll check in the lab if there is any pre-transfusion sample available. The basic coagulation test will be done. We will do a complete coagulation workup here. These are patients, you're not going to, any serious bleeding, you are going to do the full workup. You're going to do all the factor assays, you're going to do platelet function test, global test of hemostasis such as thromboelastogram or ROTEM. If they've received a recent blood transfusion, wait for 4 weeks and then you test because they're stable now, correct? So this is the approach. You know, what is critical, what is not critical, whom to evaluate, with what intensity, at what time point, and how to kind of stabilize them. That's the practical approach that I wanted to talk about in today's talk. There is some more additional information. This is more for you to refer to uh, if and when you have a patient like this. And these are some details of coagulation tests, how we interpret them, what in a normal patient, PT, APTT bleeding time, platelet count is normal. In thrombocytopenia, bleeding time is prolonged. Platelet function test, bleeding time is prolonged. uh, Prothrombin time, PT is prolonged in vitamin K dependent factor deficiency. APTT is prolonged in factor 8, 9, and von Willebrand disease, von Willebrand antigen deficiency. So just an overview of the common coagulation issues. Then a little bit of our approach when you actually send a patient to us for, thorough coagulation testing, those who have serious bleeding. We take a history, we'll check the platelet count if that's normal, PT is prolonged, those are our differentials, right? APTT is prolonged. I told you we look for factor deficiency or an inhibitor, that is lupus anticoagulant or acquired hemophilia. Bleeding time is prolonged. We'll do platelet function test and figure out, is this a drug effect? Is it Bernard-Soulier syndrome, Glanzmann's, etc. And everything is normal, but there's bleeding. Like I said, we're going to look at factor 13 deficiency, where you get this delayed bleeding after surgery or delayed bleeding from the umbilical stump. A small practical guide to transfusions: give platelets if there's bleeding, even if the counts are normal, but the patient has received aspirin and there's post-operative bleeding or post-traumatic bleeding, give platelet transfusions, right? Or in those who have a platelet function problem. FFP has all the coagulation factors, right? So anybody with prolonged PTAPT and bleeding, remember, if there's no bleeding, don't treat the number. Don't treat prolonged PTAPT if there's no bleeding. So prolonged PTAPT and there is bleeding, like I said, in a serious patient, you can go ahead and give FFP, right? Um, there's something called as massive transfusion. What happens in patients who have had a lot of bleeding? You have to give a lot of PRBCs, packed red cells, and when we give in adults, when we give more than 4 units of packed red cell or 4 units of whole blood, then the coagulation factors and platelets are going to get diluted. And that can again increase the bleeding, right? So if you are giving 4 PRBCs, after that, give 4 FFPs. It's called as the 1:1 rule. After 8 units of packed red cells, give 8 units FFP and 8 units of platelets. Again, 1:1:1 rule. So this is a massive transfusion protocol because we're giving a lot of external blood, which is going to be deficient in platelets and coagulation factor, right? So you have to complement it with FFP and platelet. Now, this is just in general. This is not for people with hemophilia or whatever. This is just for people who need massive transfusion, either due to a trauma or post-op, whatever. So this is the massive transfusion protocol. If you know a patient's diagnosis, hemophilia A or B, then there are coagulation factor injections available. If you don't have the injections, you can give FFP for both hemophilia A and B. For hemophilia A, you can just give cryoprecipitate. It comes in a smaller volume, so less fluid overload. There are two other hemostatic agents that I would like to tell you. One is tranexamic acid, very useful for mild, minor mucosal bleeding, right? It comes as a 500 milligram tablet or an injection. So you give 1 to 2 tablets or injections up to 6 hourly you can give. It's very good for mucosal bleeding, epistaxis. You can put drops of the injection in the nose or swish and swallow. Take a tablet, crush it into some water, and we ask the patient to swish and swallow the tranexamic acid tablet. Very good for superficial mucosal bleeding. It's a antifibrinolytic. So what it does is, once a clot forms, it will not allow it to break. Yeah. And that is why we don't use it in UTI, urinary tract bleeding. Because if there is bleeding in the ureter because of, say, ureteric calculus, okay, a clot is formed and you give tranexamic acid, it will go in the ureter. It will not allow the clot to break, leading to obstruction. Same reason why we don't use tranexamic acid in intracranial hemorrhage. Blood in the brain will clot, and if you give tranexamic acid, that clot will not dissolve, leading to obstructive hydrocephalus. Third contraindication is liver dysfunction. So this is one useful, hemostatic agent, provided you understand when to use it and when not to use it. Then there is another drug called activated factor 7. Also, the brand name is Novo 7. This is a panacea. You give factor 7A to any patient, the blood will clot. Whether they have hemophilia, they have Glanzmann's, it will clot. The only problem is it's expensive. You have to give it Q4H, Q8H, but it can be used in an emergency to stop torrential bleeding when it's not responding to your FFP, etc. However, after 2 doses, if the bleeding doesn't stop, even this will not work. So this is my practical overview of coagulation and bleeding for all of you. I'll be happy to take questions.
So the umbilical bleeding,
Yeah,
generally after 5 to 7 days, the umbilical cord will fall off.
yeah,
And if at all, if there is a bleeding, maybe was scanty bleeding for a day or two, then it will
yeah.
dry off.
Mm.
Suppose if the bleeding occurs maybe after 10 days or 14 days, again that is for a day or two, whether that is significant or
That's not
how, when do you
significant.
consider that is significant?
Uh, See, if it is significant, everyone knows what is usual, little bit of blood, couple of drops, that's fine. When it is significant, the mother will bring the child saying, see, he's bleeding from here, right? Uh, so bleeding which starts after 2 3 days, uh, and it's oozing continuously, that's significant. Uh, yeah, that's how it is. There is no objective way of determining it. If you ask anybody about bleeding from umbilical stump, they'll just say no, no. They'll look at you as if, why are you asking a question? So if there is bleeding, they'll themselves say that no, 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 there was bleeding from the umbilicus a few days after he was born. So, but there's nothing objective.
Okay. Thank you, sir.
All right. As usual, I'll upload this video on our YouTube channel probably by in a day or two, and feel free to reach out to me if you would like to discuss anything. Right. That's my mobile number and email ID.
It's a good refreshing class, sir. Thank you very much.
Thank you, buddy. Thanks. Good night.
Thank you, sir.
Bye.